Good morning, all. So, welcome to the final module of Basics of Allergen Immunotherapy course. And today, uh, we also have the examination, the exit examination. So, without any delay, we want to start today's session, and we are really fortunate to have two faculties with us. We have with us Dr. Sowmya Nagarajan. Madam is currently an renowned allergist at Bangalore. So, welcome, madam. And also, we have with us Dr. Gayatri Pandit, madam. She is also a very well known allergist and teacher in the field of allergy medicine in India. Madam is currently practicing in Bangalore. So, welcome, madam.
Thank you.
So, we will start the case-based discussion today. And now may I request Dr. Sowmya madam to start our lecture.
Good morning, everybody. Thank you, Dr. Shambho, for making us a part of this important module and an opportunity for the lecture today. So, in the series of concluding part of this lecture, today we are focusing mainly on approach to allergen immunotherapy based on few clinical scenarios. Our main focus on the allergen immunotherapy would be mainly in how to approach a patient in whom which patients allergen immunotherapy can be considered, and which predominant allergens have good evidence, and how should we be practically approaching that patients. And I thank Dr. Gayatri also, because she helped me with this the slide presentation of this as well. So thank you, Dr. Gayatri. So why we are talking about immunotherapy? Why is the focus on immunotherapy recently? It's majority of the guidelines like allergic rhinitis and its impact on asthma, even the GINA guidelines. So they feel that after optimization of pharmacotherapy, which we all do, and try to better the quality of life of the patient, and give them importance or education about allergen avoidance as well, can we do something more to improve the quality of life, or reduce the need for pharmacotherapy in the long run? I think that's where immunotherapy will help, because there has been a lot of evidence regarding halting the atopic march by allergen immunotherapy. So we have heard the previous lectures also. This may be a little repetition, but I thought before we go on to the allergic immunotherapy, some basics would help. It's not that we start immunotherapy and we start seeing the clinical response on immediate basis. This takes quite a long time, and that is why the period of immunotherapy is also varying between 1 to 3 years, upper limit being 5 years. So we see type 1 skin reactions, that is wheal and flare reactions, what we do for the demonstration also takes quite good few months to start seeing the declining trend. And immunological basis would be more immediate. So we may see a decreased mast cell response and increase in the T regulatory cells, which are mainly responsible for switching from TH2 pathway to TH1, allergic to non-allergic pathway. So even though the response in the immunological level is quite immediate, clinical response does take some time. So it is important that we educate the patients regarding this, and the need for continuation of pharmacotherapy even when we are starting allergen immunotherapy. So these are a little earlier studies, which was one of the landmark studies which was done about a couple of decades back. But this is one of the hallmark studies when we are talking about allergen immunotherapy, prevention of asthma, PAT study, where they took children with asthma, with allergic rhinitis, and they randomized them into the patients who are receiving immunotherapy and who did not receive immunotherapy, only continued with pharmacotherapy. This was mainly for grass pollen, birch allergy. And they followed up these patients for a period of 12 months and then again at 24 months. Significantly, I think as the follow-up happened, the patients in the group which received immunotherapy, the chances of having asthma was only about in 1/3 of patients as compared to the control group. So this was one of the landmark studies which advocates immunotherapy even in the pediatric population. And several studies have followed up along the years, showing that the newer sensitization after 3 years, 4 years is lesser in the cohort receiving the immunotherapy group as versus the control group. So definitely it helps prevention the progression of atopic mass from allergic rhinitis to asthma or newer sensitizations and gives good control of the disease. So when should we be talking about allergen immunotherapy? So mainly, I think we must be very sure in which patients we can think about adding on allergen immunotherapy along with pharmacotherapy. Mainly, allergic rhinitis diagnosed patients where we have evidence of IgE sensitization, either through skin prick test or a serum-specific IgE through immunocap. Symptoms, definitely when we have a skin prick test, we always go back and try to correlate with the allergen exposure to the symptomatology. Mainly patients who are having moderate to severe symptoms of allergic rhinitis, in spite of being on good dosage of pharmacotherapy and or avoidance measures if they're trying to do, and if they are still having persistent symptoms, I think they may be good patients. Again here, the asthma must be well controlled when we are before we start about thinking of initiating allergen immunotherapy. Some patients are there where they don't want to continue long-term pharmacotherapy and we are willing to explore other options. But here the patients must need to continue pharmacotherapy until sometime into starting of allergen immunotherapy. And as we discussed earlier, patients who have had allergic rhinitis, where the family history of atopy is more and we think that the atopic match or asthma development is high, we may be thinking in those patients also to start about allergen immunotherapy. So what is second history? I feel we all of us emphasize that the allergy testing, whether be through skin prick test or through serum specific IgE, it's only an immunological test which tells us that the patient is sensitized. That means to say the patient, he is having IgE antibodies against that particular allergen, but we are not labeling them as allergy. It is always important to go back to the patient symptomatology and try to correlate with the test report we have. We don't treat the report, we treat the patient. So that is very important and that helps us by second history. So it is very important that we have to go back and revisit the history again, try to ask more leading questions with the test report we have, or even before we are starting immunotherapy, because that helps us narrow down what relevant clinical allergens we may be choosing for allergen immunotherapy. So there are few very practical questions we must be thinking before we embark on the long journey of allergen immunotherapy. Mainly, is the patient an ideal candidate for immunotherapy? Mainly, we did discuss about the few indications earlier for immunotherapy, where they have allergic rhinitis or associated rhinoconjunctivitis, where the increasing dose of pharmacotherapy is more, or the quality of life is being affected, and the severity or the exacerbations is intermittent interval symptoms are increasing. I think these patients may be ideal candidates for immunotherapy. And what are the allergens which we have got sensitization on the skin prick test or on the immunocap? And what should we be, which is the main allergen we should be focusing on based on the symptomatology? Say if it is dust mite, be it DERP or DERF, The symptoms may be perennial throughout the year, but exacerbations, mainly the symptoms happen when the child or the patient is indoors, when they come in the bedroom to sleep, or late night, early morning. So, or if it is a particular pollen season, where in that particular time of the year, the patient gets more symptoms. So, it is important to go back to the history to narrow down which is the possible main allergen causing the symptoms. And also, we should have certain degree of cross reactivity knowledge, because some allergens may have similar structural proteins between sharing between them, and that may be the reason, say for dust mite, if they are allergic, the similar protein is because of tropomyosin. I think it has a shared structure between cockroach and shrimp as well. So sometimes, if it is a panel of tests done somewhere, we may see positivity, the sensitivity to cockroach and shrimp, but the patient may be eating shrimp all the time without any issues. So we should not be telling that patient not to stop eating shrimp. So it is important to have this certain basic knowledge about cross reactivity, and what is the proper dosage and how much longer duration immunotherapy would be required. And it is very important that we are not aiming to stop pharmacotherapy as soon as we embark on the journey of allergen immunotherapy. We have to continue using the pharmacotherapy when the patient is on immunotherapy. I tell them it's not like a magic bullet. We start immunotherapy and the symptoms would go away. Like we give paracetamol and the fever would come down immediately. And we are addressing the basic issue of what is the allergen which is causing the symptoms. It does take some time for the symptoms to get better, but it's important to educate the patient that they continue taking immunotherapy, pharmacotherapy when we are starting on immunotherapy. So, cross reactivity mainly in the dust mite, I think DRF and DRP, they have very close cross reactivity. The similar structure is same, whereas the other storage protein called Blomia tropicalis is a little different. So, if the patient is sensitized on for DRP and DRF, sometimes we may end up choosing one which is a predominant allergen, and we may not be needed to require to use both of them. And if they are sensitized along with the dermatophagoids uh, species, and again if they have sensitization to Blomia, we may choose one of these and along with Blomia. So there is high degree of cross reactivity between the dermatophagoids family. So it may not be needed to use both of them when we have sensitization to other as well. So depends on the patient, second history, and how we choose to choose which allergen for immunotherapy. I think this is a very exhaustive list. This is courtesy Dr. Gayatri. I think this is her personal preparation and she's very good at it. Probably I will leave Dr. Gayatri to explain it further, but I think she's very nicely highlighted in the similar colors where the some of the pollens which have cross reactivity, and if they are sensitized to both, we may go to the second history to choose the allergen of choice for immunotherapy. Say for weed pollens like Parthenium, Mugwort, or Xanthium, predominantly Parthenium is a very common sensitizer in the south. So we may end up choosing Parthenium if there is also co-sensitization to Mugwort and Xanthium. Dr. Gayatri is very good at pollens, and I leave this to her to explain in detail. So it is also important to know the protease content of various extracts of allergen extract, because protease are the enzymes which has the potency to break down the protein content, which is mainly important what we are choosing in the skin prick test extract or in the allergen immunotherapy. As by the chart highlighted, the dust mites have low protease content as well as the pollens and pet dander. I would like to draw your attention to the lower half of the table where molds like Alternaria, Aspergillus, Penicillium, they have high amount of protease content as well as cockroach. So having this basic knowledge will help us to choose if we, what allergens can be mixed and what cannot be mixed. We should not be mixing high protease containing allergen extracts like fungus and cockroach with dust mites and pollens, because they break down that protein content and render it not effective. So traditionally, as a thumb of rule, we do not mix high protease containing allergen extract with low protease allergen containing extracts. So how do we choose the dosages of antigens for allergen immunotherapy? So these are all derived from prospective cohort studies, which have studied the effectiveness of each dosage of the particular allergen and at which dosage it has rendered more clinical and immunological response. And mainly house dust mite, we would be typically thinking of about 20 micrograms of dust mite protein containing extract per month, and pollens around 50 micrograms per month. Cat and dog also would be around 40 to 50 microgram per month. Alternaria 3.5 microgram per month, but because it has a high protease containing extract, we seldom choose immunotherapy for fungus. So this is a review paper which very beautifully depicts the level of evidence for different allergens and which has the highest level of evidence for immunotherapy. As very nicely depicted, the dust mite has the highest level of evidence, that is highest level of evidence along with dust mites and pollens. Almost half of our patients are sensitized to dust mites, and I think it, because it has very good level of evidence for immunotherapy, I think the most of us do immunotherapy for house dust mites. So it is generally very effective. Even with standardized allergens, the level of evidence is further more, as well as the pollens have been shown to have good degree of evidence for immunotherapy. Not much so for the cockroach and molds. As we were telling, there is limited efficacy, and because of the high protease content, we may not end up choosing allergen immunotherapy for the same. So whenever we have access to the standardized allergen extract, please use it whenever possible. Having said that, the access to standardized extract is not great in India. I think in the next couple of years, we may have more access to standardized allergen extract. Sometimes, because of the logistical issues, we may end up using non-standardized allergen extracts, but try to use standardized allergen extract whenever the symptoms we have access to it and cost is the not the factor. Very important that we should not be starting immunotherapy when the patient is symptomatic or having uncontrolled disease. Very imperative that be it asthma, the controller medicines have to be initiated and it has to be well under control. Allergic rhinitis, continue the inhaled corticosteroids, intranasal steroids, and keep it under control. And then we should be thinking about starting immunotherapy, be it rhinoconjunctivitis as well. So make sure it is well controlled, and then if we think immunotherapy is going to benefit the patient, we usually try to sensitize the patient on the follow-up when the patient is doing well. And if we think, we tell them what is immunotherapy, we give them time to think. And then once their symptoms are well controlled, I think that may be a right point of time when we have to be thinking about immunotherapy. I do not usually do more than one allergen immunotherapy at a time. I think Dr. Gayatri would be covering more on that. But as even when I have begun, and probably most of my practice now, I stick to single allergen monotherapy. If we think it is requiring a little more allergen immunotherapy, I think it would be better we seek guidance of a senior who would have expertise in the same. Coming to few clinical case scenarios, this was a 9-year-old girl presenting with runny nose and stuffy nose with sneezing since the last 6 years with symptoms mainly being perineal and sneezing more in the morning and nasal block, which is bothering her night sleep. Symptoms are predominantly indoor, and patient has undergone adenoidectomy the last year, for following which mouth breathing and snoring seems to be better, but her nasal symptoms are persisting. There has been no change in this symptomatology, whether the child was in Chennai earlier or when they have relocated back to Bangalore. Mainly, when we go into a little deeper history on the environment, I think being in the allergy practice, we have to take a more detailed history regarding the surroundings as well, giving importance to whether there are any possible mold exposure. Sometimes if we just ask molds, they may not tell molds. We have to go down whether they're seeing any black or green growth, or if there is any propensity for water, standing water, everything. So I think we have to go a little more into the detail. This patient had no pets at home, no history of damp walls, and they say occasional cockroach, but in our house there is no cockroaches. Had few soft toys. The child is on mometasone nasal spray with minimal effect, and the child has family history of atopy in that mother was asthmatic. The skin prick allergy test show sensitization mainly to DER-F and DER-P, with sensitization to Blomia as well. And we have sensitization to cockroach with good negative, that is saline, and good positive, that is histamine controls. So here we have this child with the good clinical history and sensitization to skin prick allergy test. So the next question comes, is this child a good candidate for immunotherapy? I feel this child has undergone adenoidectomy. It was a surgical procedure, which it has helped her snoring and mouth breathing to get better. But in spite of using intranasal steroids, this child is having symptoms, and she has compromised quality of life, and given the strong background family history of atopy, I think she may be a good candidate because the disease is on the moderate to severe spectrum in spite of optimal pharmacotherapy and other comorbid conditions being taken care. I think she may be a good candidate for immunotherapy. So which allergens we should be considering for immunotherapy in this child? Mainly, we have seen that the child had sensitization to mainly dust mite, DER-F and DER-P, dermatophagoids. As we were discussing, there may be a good cross-reactivity between dermatophagoids, both of them, and Blomia. I think we could be either choosing one of these along with Blomia, and there is nothing wrong also if we try to choose both dermatophagoids and Blomia. But sometimes when it comes to logistics and economics, we have to take that also into consideration. And probably, I think both are okay. But I would probably lean more towards choosing dermatophagoids, one of them, and Blomia. Should we be adding on cockroach immunotherapy here? Because it also shows sensitization to cockroach. As we discussed earlier, cockroach and fungus have a high protease content, and we should be we should not be mixing these immunotherapy with the low protease content, and the level of evidence for cockroach immunotherapy is also not that great. So I think we may be end up giving immunotherapy mainly for dermatophagoids and Blomia. It's also important that before we start the immunotherapy, the symptoms, at least we must be trying to optimize pharmacotherapy. Along with intranasal steroid, we may add on a nasal wash for the same. So, yes, as we were discussing, we may end up choosing one of the dermatophagoids, and cockroach allergen should not be considered for immunotherapy. Now, coming to case 2. So, this was an 8-year-old boy who had history of nasal blockage throughout the year for the last 3 to 4 years. He has persistent nasal clear discharge, which becomes very troublesome with incessant sneezing, itching, and cough during the autumn and winter seasons. He's also developed shortness of breath and wheezing episodes. In the last year, at least he has had 3 times such episodes. And because of his respiratory issues, he has led to a lot of school absenteeism um, each time. So this child has been taking daily oral antihistamines and also on fluticasone nasal spray, and he is on intermittent use of inhaled corticosteroids. There is no history of, and he uses salbutamol as when needed, but for a short period it helps, but then his symptoms tend to come back. There is no history of hospital admission or requiring to be prescribed oral steroids. This child also has a strong family history of atopy, with elder sibling having atopic dermatitis, and mother has allergic rhinitis. So in this patient, I think important is to optimize the pharmacotherapy. So I would be asking the child to be on regular, we get a pulmonary function test done, and make sure we start the patient accordingly on a preventer therapy. In spite of being asymptomatic, it is important that we educate the patient to be on regular inhalers. And once his symptoms are under control, um, we proceeded to do an allergy testing, which was sensitized for DERPI and DERF only, with others being all negative. So we advise the patient to take house dust avoidance measures as discussed in the earlier modules. But this patient continued to have some, yeah, he was symptomatically a little better, but um, he was, the parents were further willing to explore other treatment options, which would give him better relief. So what would be the next logical step in the management of this child? I feel here, because a child has moderate to severe allergic rhinitis, and um, on the pulmonary function test, we had mild obstructive airway disease, mainly involving the smaller airways. Doing better with the inhaled steroids, we could explore the options of allergen immunotherapy in this child, because the quality of life is affected and he misses school because of this. I think here the most logical option to choose was only for house dust mite, because he was sensitized to only DERPI or DERF. So I think this child would definitely be better with optimization of pharmacotherapy and add on allergen immunotherapy in this patient. So, and I think now he's close to about 9 months into his, after starting immunotherapy, he's doing considerably better. The symptom score seems to have come down. We are continuing pharmacotherapy on a low dose. This was, this is my last case. The 12-year-old girl presented having incessant sneezing for the last few years. Again, typical allergic rhinitis history. This child also has symptoms of itchy, watering eyes since the last year. She has lot of history of rubbing the eyes, and once it starts, she does not want to stop. She feels that once rubbing is there, that will control her symptoms to a little extent. And she also has a little bit of visual impairment. She has a dog at home since she was a baby, and she's very anxious that it has to be separated, because her mother is telling that it causes, it may be causing her symptoms. So on examination, nasal, she had highly enlarged and boggy inferior turbinate hypertrophy. She has dry skin. However, on the eye examination, this child had the giant papillae at the limbus as well as the cobblestone appearance under the eyelid, which is very typical of the allergic conjunctivitis. The ears and throat examination were unremarkable. So, in patients, when we have this ocular allergy associated with respiratory allergies, it's important that we have other specialty like ophthalmologist to be involved, because they will help us in better control. And this child also had, because visual impairment, mainly because of extensive eye rubbing, it may have progressed to other ocular complications. So this child was started on intranasal steroids and second generation antihistamines once a day for 2 weeks. Once she was a little better and we were able to stop antihistamines, she underwent skin prick test evaluation, which showed sensitization mainly to derpy, DRF, Parthenium, and dog epithelia. She was accordingly advised appropriate avoidance measures. The ophthalmologist got back to us saying that the child has keratoconus, which is a complication of the severe eye allergic disease, and has given topical medications for the same, and avoidance measures regarding goggles and not rubbing the eyes vigorously. So in this patient, this child was better with all the optimization of pharmacotherapy, and the intranasal was continued with antihistamines being stopped. So how would you be proceeding further in this child? I think this also maybe she will benefit given that her disease is on the moderate to severe spectrum, and her symptoms are well controlled with the optimization of pharmacotherapy. Once keratoconus has set in, we cannot reverse the disease, but to give control of the disease is also important, because we cannot keep on using the need for topical steroids would also come down. So I think this patient would be concurrently started on allergen immunotherapy mainly for dermatophagoids, because here she was not sensitized to blomia. And afterwards, um, uh, she's on regular follow-up, and we have stopped intranasal steroids, and she does require topical eye medications continuing, and definitely I think her quality of life has improved, and she wants to continue concentrating on other aspects which were not possible earlier. So I think it's important to choose the right candidate for immunotherapy. We should not be in a rush to start immunotherapy for all patients. I think the success of the program of immunotherapy lies in proper patient selection. So, mainly, I think it's important to discuss the benefits of immunotherapy, be it subcutaneous or sublingual, with the patients earlier before we embark on the journey of immunotherapy. It's important to continue the medications, whichever is there, uh, before when we are starting immunotherapy as well. We have to be specific of which condition we are giving the immunotherapy, what is the possible adverse reactions during the course of immunotherapy they can have, how often do they need to visit, what are the cost effectiveness and benefits. So it's all important to discuss in advance before we actually think about starting immunotherapy. I feel the gaps in the knowledge mainly is the efficacy and safety of multiple allergen subcutaneous versus sublingual. Those certain studies are there. Prospective studies will help further. And in the pediatric population, I think whether we can, if there is a strong family history of atopy, and are we justified in starting? Many studies have shown no, but probably there may be better scope for improvement in the pediatric aspect is what I feel. And determining the target maintenance dose, necessary durations for both skit and slit, direct comparisons head to head in the pediatric and adult population is not very much there. I think these are all, maybe we will be having answers to this question as more data comes up in the uh, next few years. So thank you for a very patient hearing.
Thank you, madam. Thank you very much for this wonderful summary lecture. Uh, so now may I request Madam Gayatri Pandit
Yeah.
to please
Um,
start the lecture.
um, yeah, are the slides visible?
Yes, madam.
Yes, ma'am.
Yeah. Dr. Shambho, I also wanted to know if the candidates can interact with the lecture, like they can put the chat box answers or anything now when I'm giving a lecture.
Yes, yes,
Okay.
yes, madam. They can. So I am requesting all the participants who are there, so to please write down your answer when madam will ask some question, and so that we can take up those questions.
Okay.
And I am
Yes, it's
requesting
going
our
to be only case based from this thing. Another 3-4 cases we will discuss. So it
Hmm.
will be good if they interact. So we
Yes.
will. Okay. Okay. Yeah. Thank you. Thank you, Dr. Sowmya. It was very nice to hear the flow in which you gave the gist of immunotherapy with few case scenario, and that becomes a little solid background for me to get into some other cases. Before starting in for an immunotherapy, I always tell on that what do you counsel the patient for allergen immunotherapy. So it is not that all your very exciting skin prick allergy test results will translate into immunotherapy, right? So you might have done an SPT, have seen a huge reactions of a resinus of a 10 into 12 or sometimes even a 20-30 millimeter reactions also. That does not mean that at a very first discussion of your skin prick allergy test with your patient, the same time the patient gets converted into immunotherapy patient too. No. So usually you need to give some time before you execute immunotherapy. See, it is something a therapy which will go for a 3-year time, and it requires a lot of commitment and understanding from patients, and you also might need some more time to understand the patient's environment around and what is happening to execute that, where exactly that you need to target. So what I usually do is post my SPT results, and when I'm taking a little bit of a second history to correlate, so I usually just introduce the concept of immunotherapy that time. So I usually don't start or don't talk everything about immunotherapy during that time. And I focus more on environmental control measures that time and ask them to come back after 1.5 month or a 2 months time after executing these environmental control measures and also optimizing the pharmacotherapy. So during which also what happens is patients looks back into second history by himself, because they wouldn't be thinking that that would be a culprit allergen, and they would have never ever thought on that, because most of the time patient perceptions are only on the food, and they would have always thought that some food is causing a trigger. So they wouldn't have thought that some patch on the wall would be causing them a trigger, cockroach would be causing them a problem. So they would have never thought on that. So I give a time to correlate their second history too, and I take a second history again at the end of 1.5 or 2 months time when they come again. And that time is where the counseling on immunotherapy will go, where you will tell that what is the expectation from immunotherapy, because patient expectation is always a cure, right? But your line of a counseling will be that, as Dr. Sowmya put up a different level of an evidence, your line of a counseling will be that you should tell patient that I'll be probably be able to give you better medication score, better symptom score, and your quality of life will improve. I will probably be able to prevent a neosensitization, and I will be able to prevent the progression of the disease, because immunotherapy is only a disease modifying treatment that is available. And the main advantage also is the effect of immunotherapy will last even after I stop even after I stop immunotherapy. So these are the counseling lines that are the promising lines that you will use while counseling your patients for immunotherapy. and it is difficult to commit for a term of a cure. So what I often tell is, see, if your symptom scores are on a scale of 0 to 10, if you are on at around 8 or 9, I'll be able to bring it down to 1 or 2 for sure. And if you are doing very good, you might be at 0 also. So by telling this, you are definitely promising them a better results with this, and on the same line, you are also not promising that 100% everything will be all right, which you cannot actually promise with anything too, right? uh, so with this background, let me come to case scenarios. Okay, so I have a patient here who is Aryan, aged 8 years. He is from Bangalore, with a history of runny nose, sneezing since last 4 years time, and more in monsoon time. So last 1 year, he also has a frequent episodes of a cough. Sneezing is more in morning hours and cough is more at night time. There are exercise induced symptoms, and there was one episode of acute urticaria also when patient went to grandparents' house recently. Father is asthmatic and was seen by myself an year ago, and had responded to intranasal. The patient was actually seen by me 1 year ago, and he had responded to intranasal corticosteroids very well that time. Since he became better, he was lost for a follow-up. So since he also had a cough episodes, I did a PFT, and the pulmonary function test showed mild obstruction with good reversibility. And this was his SPT report with consider it to be with a good positive control and a negative control, saline being 0 and the histamine being 5/5. So he was sensitized to D-farine 6/6, D-tyronicinus, the another dust mite 8/8, Blomia, which is storage mite 6/6, Chenopodium alba and Amaranthus spinosum. So these two weed pollens were positive 6/6. So now, by history, is he a good candidate for immunotherapy? So if you feel that he is a good candidate or he is not a good candidate, please put up why. I'll give you 1 minute. I'll just wait for your response to be. So please type, is he good candidate for immunotherapy, and what are the key observations that you have seen in his history? Anybody, please.
I think, madam, they will type in the chat box. Yeah, Dr. Povitra Banerjee already. What
Yeah,
are
so
the...
this is response, because if I type on that, I think my screen,
Yeah,
it will.
no, there is no response there. So, madam is asking, is he good candidate for immunotherapy and why? So, can you please just type in your chat box? Questions will be taken later, but I am just, madam is now asking this question. So, we need to wait, madam, little.
Yeah, just another 30 seconds, I'll wait. If not, I will just go further. Okay, I'm putting back to that history slide. And by history, I would want you to...
Yeah, so Dr. Povitra Banerjee had tell that yes, the cause he had mentioned less age, less duration.
Okay, so what he meant is a
Dr. Bhaskar,
young patient. Yeah. One of this thing in a immunotherapy that we see is a young patient and a young disease. So yeah, that is one factor that I would think. But yeah, we would also start immunotherapy when a patient is 30, 40 years also. But yeah, young patient is one of the very good responders. See, I think there are other couple of responses also, right? So anything, this thing,
yeah.
Dr. Shako?
So Dr. Krishnan is from Kochi tell yes. Dr. Swati Malani from Vadodara, yes, as he is progressing towards asthma.
Correct. That's a very, very key point here. The progression of the disease. So, what is allergy is a progressive disorder. So, that is what I wanted to catch here in this history. It is a progressive disorder, and you are seeing the progression already here. And the family history of asthma is there, isn't it? So, if you keep this, boy untreated, there are much more chances that, he is asthma will get more and more established. So what are the signs of a progression usually? Like, the nature of you are seeing that from allergic rhinitis to asthma being there. The other progression of the disease could also be that patient having an intermittent symptoms earlier and going in for a more persistent symptom, patient not responding to the usual pharmacotherapy, patient requiring a frequent reliever medications. So these are the things where you will judge as in whether the disease is progressing or not. Thank you for all those responses. I think there are much more responses which have come also, right?
Yes, yes, yes. Many responses are coming.
Yeah.
So, yeah.
Good that I know. I get a little confidence when the responses are coming to go further. So yes, you all are right. So he is a good candidate for immunotherapy for a couple of reasons. That a young disease, young patient, you have a good chance for a modulation by immunotherapy. Disease is showing a progression, and is a history correlating. So by history, what do you think is a correlation? And this is a SPT report. So what correlates with the histories? Anything, it may be little more for you to ask on an aerobiology correlation and all, but at least on the dust mite, by end of this program you should be able to correlate.
Someone mentioned that this is a perennial one. So,
Excellent.
yeah,
Yeah.
so Dr. Jamie from Itanagar. So, again, Dr. Uh, there are multiple responses are coming.
Okay.
Yes, Dr. Kaushik Mukherjee from Kolkata is mentioning good candidate for immunotherapy. He has mild symptoms, controlled well with pharmacotherapy, and he is in early age. Dr.
Agree.
Smita Satpathy from Bhubaneswar telling yes, with ongoing progression of March. Yes, she requires immunotherapy. Dr. Povitro Banerjee is again telling sensitized to house dust mite. So yeah, there are some responses are coming.
Correct.
And you can,
Good.
yeah.
Yeah. So what I wanted to tell you here is that, see, now we have decided that he's a good candidate for immunotherapy. Now I have an SPT, right? Now I have to see that whether my SPT and his symptoms are matching, and if I'm starting the immunotherapy, which allergens to choose. So how does a house dust mite allergy presentation? So even by history, sometimes you will be able to roughly know even before doing an SPT that this patient is going to have an dust mite allergy. This patient is going to have an pollen allergy, like that. So dust mite patients usually will have perennial symptoms, more of an early morning symptoms or a night symptoms. More often, a early morning sneezing is that very typical symptoms of for these house dust mites. So by that, if you correlate the dust mite and this one very well correlates, and patient have little more symptoms in the monsoon season. So he has a perennial symptoms. In the background of perennial symptoms, he has more of an exacerbation during the monsoon season. Now, that kind of an exacerbations can happen in dust mite alone, because dust mite breeding, less of an avoidance measures, everything is, again favors the growth of dust mite more in monsoon season. So just a dust mite alone also can have exacerbations of symptoms in the monsoon season. But the two pollens which you are seeing here, Chenopodium and Amaranthus, both of these also pollinates during monsoon time. And to my area of practice, where I'm practicing in Bangalore and the patient is also from Bangalore, the Amaranthus remains as an significant pollen for me. Now, among Chenopodium and Spinosum, there is a cross reactivity. I hope you know what is a cross reactivity. Cross reactivity means they actually come from the similar family of the species. Okay, so there will be high degree of a similar protein being shared between these two species. So we don't need to treat both the pollens. So we can treat only one pollen. And as Dr. Sowmya was mentioning in the morning, so we don't need to probably treat all these three dust mite. I will stick on to DP and Blomia, because I know that the Blomia has a little less cross reactivity with the other two. So I will end up choosing for this patient D. Tyrosinus, Blomia tropicalis, and Amaranthus spinosum. I think I missed one slide before telling you. Yeah. So while initiating a immunotherapy, this is how your learning curve should be. The first few cases of your immunotherapy, you should try to stick to either a mild disease or a moderately severe disease, especially started with an allergic rhinitis who are HDM sensitized, like few cases where Dr. Sowmya mentioned already, because they are usually a best responders, and you will get kind of an confidence. If you see a result, then you will start practicing that more, right? So you should see a good result. So don't try to choose somebody who is polysensitized or having partially controlled disease as your first cases. So choose these as your first cases, and then what you start choosing your cases is, even in polysensitized patients you can do monotherapy. So then next step, you can choose these polysensitized patient but still practice monotherapy on basis of your knowledge from a second history and from the cross reactivity. And once you get a hand of this in in another 1 or 2 years, then you can start initiating immunotherapy in a little tougher cases, where within moderate asthma, where you might need to prepare allergens, or where you also might to prepare it as in two kits. So next case scenario. So we have a 30-year-old female patient presents with a history of runny nose and sneezing and watery eyes since last 5 years. Okay. And mostly in the morning only. Patient feels itchy all around her face too, and symptoms get better as the day advances. And also, once the patient is at a workplace, her symptoms are better. So patient feels absolutely fine when she is on vacation, and patient has been in Bangalore since last 10 years, but her symptoms are since past 5 years. And when I do a skin prick allergy test, all the negative reports I have not put it here. So it was DF 2 by 3, DP is 4 by 4, Blomia is nil, Parthenium is 2 by 3, Ricinus communis is 8 by 10 with the pseudopodia, Fusarium is a fungi which is 3 by 3 with again the good, positive and negative control. So what is this? What is this patient predominantly sensitized to? Ricinus communis is a pollen. Okay, so it is a pollen. So with this pollen in this background, do you want to take any second history? Patient seems to have a very mild sensitization to dust mite, a very slight sensitization again to fungi, but seems to have a very strong reaction to one of the pollen called as a Ricinus communis. So now you want to understand about this particular pollen little more. So do you want to ask any second history to your patient? So I'll just put the history, this one back, so that you can read the history back and tell me what second history that you would want to ask. See, being an allergologist is very much like a detective sometimes. So you really need to, we are a people who ask environmental histories, probably like, no one else who takes the history. You will be asking how is their house, how is their kitchen, how is their AC maintained, what is there next to their house, all those things that we will be asking. So yeah, what are the responses that I've got?
Yeah, so Dr. Jethwa from Bharuch asking any indoor plants. Dr. Vaskar asking about any seasonal exacerbation of symptoms.
Yeah, there is correct. Seasonal exacerbation, I have not put it here. Yes, you could ask for that. Seasonal exacerbations are usually in the winter between October to Jan is her exacerbation. And no indoor plants. And one other thing is, most of these indoor plants, which are environmental plants or what you usually grow as in rose or hibiscus, they don't cause you allergy because they are entomophilous. They attract insects for their mode of pollination, and they wouldn't use wind for their mode of pollination. So
And
yes, seasonal exacerbations. Yeah.
someone is asking, that is Dr. Krishnan, Dr. Smita Shatpathy from Bhubaneswar. They are asking about Ricinus. Any specific history near home about the Ricinus present?
Correct. See, then what I had to go and ask this patient is that patient has been there in Bangalore for 10 years, but why did that, last 5 years? There are plenty of resinous in Bangalore. And one other thing that you all also need to understand is, you know, pollens need not be, this particular weed pollen or something need not be very next to patient's house, because you all know that the pollens travel a distance, isn't it? So it need not be very next to their house, but yes, if it is there very next to their plot, as in any empty plots or something is there, then their exposure levels will be much higher. So on a second history, then she said this, yes, they moved to a new house couple of years before, though they were there in Bangalore for some years. They moved to this house, which was, around 6 years before, and which was near a lake. And they had an empty plot next door, and they had, plenty of these, um Ricinus communis around, and as somebody was asking for the peak symptoms, she would have a very bad eye symptoms during October. You should note that this is one pollen which is known to cause lot of eye symptoms, and there are pollens like Parthenium and this Ricinus communis, where the exposure of these pollens on your face also causes itchy feeling all over the face. So if they are outdoor for a longer time, if they go on for a morning walk and where all these pollens are there, so they come back also with a feeling of an itchy face or a quite itchy eye. So I'm glad that you are catching up with the second history. So that's very nice. And there was no dampened wall or there was no significant fungal exposure. See, fungi is ubiquitous. Fungus is there everywhere. But you have to see whether there are any obvious source of fungi also. There was no obvious source of fungi. So when those things are not there, for me, the key allergen becomes as an Ricinus communis only, right? So my focus was more on to treat on Ricinus communis, and I also would want you to take a clue from this history that the place in which a patient stays and the chronology of if a patient is changing a place is also important. Like patient tells that I'm absolutely fine on vacation. That should give you a clue. Patient told that last 5 years symptoms started. That should give you a clue. That when did the patient change their house? Did the patient move to a new locality? And so, there are Bangalore is metropolitan city where you see that the people keep you get a people from a different places. They tell that I was perfectly fine in Delhi, but my symptoms have started more in Bangalore. So such kind of an clue you should take from history to narrow down on your allergen immunotherapy too. Okay. So good. So with this, we will go to the next case scenario. So we have a 25-year old male referred for a history of nasal blockage, thick nasal discharge since last 12 months time. He has not responded enough to nasal spray, family history of asthma present, and on asking patient complaints of hyposmia whenever nasal blockage is more. There is no personal history of asthma, food allergies, or NSAID intolerance. Okay. Symptoms are more in monsoon season. Nasal blockage is bad at night time. Gets triggered during exposure to dust is what patient tells. So this is the CT scan picture. So I will just tell about the CT scan picture itself. So it is you see the right-sided maxillary sinus, ethmoid sinus opacity, and maybe it was, yeah, and even the frontal sinus opacities are there. Probably the presence of polyp from the picture of the CT scan. And I also see a little bit of in here, the double density signs also. Double densities we usually is a typical feature of fungal infections. And I did a nasal endoscopy, and nasal endoscopy shows beta polypoidal changes and a thick mucoid secretions in nasopharynx. So we did a skin prick allergy test for this patient and was found to be sensitized to dust mites. We have used both standardized, non-standardized here. So that's why you see so many dust mites being there. Sensitized to alternaria, sensitized to fungus aspergillus, and also helminthisporium. So anybody who can give me the diagnosis? Good information's given already. So anybody can tell me the diagnosis? Okay. Because CRS may not be, chronic rhinosinusitis may not be covered in the module. So I will just tell that this is one variety of a chronic rhinosinusitis called as an allergic fungal rhinosinusitis. Okay. So this is a kind of a sinusitis where there is a significant fungal element being involved and there is a hypersensitivity to the fungal hyphae. And this is a picture that the usually patient develops with a unilateral sinusitis, thick discharge, little tougher disease. And this kind of a picture is going to stay for a longer period of a time. So what do you do? What is your plan for this patient? So will you start immunotherapy for this patient now? Is he a good candidate for immunotherapy or what's the plan? why I have specifically put this thing is that, so now that since you are getting trained in allergy and you might have a further interest to pursue more in allergy, right? So you will come across such cases, and then you should know that how to handle and whether you will start immunotherapy as your first choice or what would you do. So what are the responses? Dr. Shampoo, can I just can somebody read me the responses?
Yeah, so there are some responses coming, like Dr. Bhuvaneshwari telling no. She is asking about can start antifungals. Again, Dr. Bhaskar is mentioning no. Uh, Ayushri from Patna telling no immunotherapy. Dr. Krishnan is telling about ABPA is possible. Uh, yeah, so these all are the response. Dr.
ABP is
Krishna,
possible. It's ABP is possible. So there could be quite an overlap between AFRS and ABPA. In fact, the all understanding of an AFRS came from an ABPA, where it was initially thought as an to only to an extra only to an aspergillus species. But in sinus, the inflammation happens with all diatomaceous fungi. So it is not only aspergillus, and hence actually the name changed to allergic fungal rhinosinusitis. Otherwise, the initial name was allergic aspergillus fungal sinusitis. But they quite coexist. So if you suspect, you might want to do a little more evaluation towards a AFRS, ABPA also. Yes, as you all have told, there is immunotherapy is not our first motto here. Immunotherapy is not our first intention here, because whenever fungal load is there inside the body, you need to take that out, and you would not be thinking on immunotherapy as in first line. So you do a functional endoscopic sinus surgery. So this patient requires a FES surgery. Patient needs to get all his sinus opened up and the fungi opened up. And post that, we will be doing a post-op steroid irrigation. See, we know that nasal sprays are a best drug for allergic rhinitis. But whereas when it comes to sinusitis, your irrigations, your nasal spray is not able to reach till the target organ. So that is inside the sinuses, inside the frontal sinus. So that is why we will need to start a post-operative budocort irrigation with a normal saline in specific posture, so that we make the medicines enter more during more towards that side. Environmental control measures both for dust mite and fungi. So I wouldn't be keen on jumping onto immunotherapy as an initial step. I might still consider immunotherapy at the end if none of these conventional medical and surgical line of managements are not working. So the level of evidence for fungal immunotherapy is around B, and we have a variable results. So results are not very promising. So in fact, I would be more keen to probably desensitize onto dust mite and not to use it with a fungi. And you know that the fungi has a very high protease contents, and you cannot mix it with a dust mite. So if at all, if you are wanting to do, then you need to keep it separate. So the summary for this particular case for you is, don't jump on to treat fungal immunotherapy. Okay, so manage the other things. And many a times when AFRS patients are there, the first needs to be the first step and a continuation of a medical line of a management. Many a times FES is done, but there is no continuation of a medical line of a management. So these two things are to be focused. Somebody had mentioned about the oral antifungal. Oral antifungal again has a, because it is not a fungal infection, it is a fungal allergy. So role of antifungal is still questionable, and we don't have a good level of evidence to start antifungals in AFRS patients. Okay, good. So yeah. So with this, let me move to next case, maybe a last case also. Yeah, it's a little tough case. It's a 35-year-old male who was earlier staying in Haryana. It's a little complex history. First, earlier he was staying in Haryana, now moved to Bangalore, and he is presented with a history of nasal blockage, rhinorrhea, and sneezing on and off episodes, and cough. Patient was also in Ahmedabad for 1 year in between. And patient peak symptoms are in August to September and from February to March again. Okay. And he was a patient who also had undergone septoplasty, turbinoplasty earlier in Haryana. Okay. And this is his SPT report. So dust mites nil, Cynodon, Ziames, Cypress, Sorghum vulgare, all these are grass pollens. So everything showing a huge sensitization. Amaranthus, Parthenium, Ricinus, Chenopodium, everything on an higher end. Cassia, Eucalyptus, Holoptelia are also very markedly, positive. Only dust mite is not positive. Cockroach is not positive. Fungi were not positive. The rest of the pollens were negative. So these are the pollen picture that you have for this particular patient. Okay. So at the outset, at your level of an understanding now, at this point, do you think that this patient is an good patient for immunotherapy or not? Okay, see, usually monosensitized patients are better for immunotherapy. Okay, not a polysensitized patients. Polysensitized patients, there may be many other cross reactivities. There are many other things which we may be missing also. So I wouldn't want you to choose such patients for immunotherapy in the beginning. Okay, but now as we continue to practice, these patients actually would have tried everything or would have tried. In fact, he has tried immunotherapy in the beginning. He had started immunotherapy and discontinued in 3 or 4 months time because of a logistic reason that he shifted from Ahmedabad, and then he moved to Bangalore, and then and when he was on immunotherapy, he told that he was doing better, and that's why he wanted to reinitiate immunotherapy. Now this is a picture that we get, and it's very difficult to choose, right? So what do we do in such cases? We give patients some time and we ask them to take a picture of all his surrounding, and we asked him to come back with a history. So this is what he came back with the pictures. Okay. So this is a cassia. This is a cassia tree. Cassia is quite evident in Bangalore. Okay. So this is a cassia tree pollen. And this is a holoptelia. So holoptelia, we don't have much trees in Bangalore. There are only few trees, but it is a very, very important tree pollen when it comes to northern, central, and western part of India. I don't know how much. I think for you, neem is little on a higher end in West Bengal side. But for the rest of the north and central and west part of in India, holoptelia becomes a very, very important tree pollen. The other things that he got was this is called as a rain tree or a Sowmya, and the another few pictures of this he got. This definitely is not an allergenic plant, right? So this is an entomophilous plant. It is not an anemophilous plant which would cause allergy. And when I took a little more history, he stays in a mini forest area, and he stays actually in a zone where there is a long belt of a eucalyptus tree. Okay, so eucalyptus is otherwise a mild sensitizer, but when you have a huge exposure of a eucalyptus, that again could be contributing to symptoms. And has a last site behind his apartment which is full of weeds, and the patient is not very sure that whether he is going to stay in Bangalore, whether he is going to move back to Haryana, that means whether he is going to move back to north. He is not sure yet. Why I am asking this history to him is that when I'm desensitizing for a pollen, and that pollen is very specific to one area, and if the patient is going to continue to stay in that area where that pollen is not there, then patient may not really get any symptoms because of that. Like, if patient stays in Bangalore, he may be having holoptelia sensitization, but there are not much holoptelia trees in Bangalore at all. So it doesn't matter even if I don't desensitize him. But he is not sure about his plan, so I might still need to consider holoptelia for that. Okay. So what I ended up doing is that among grass pollen, there is usually little higher cross reactivity, and the longer grasses cross reacts and the shorter grasses cross reacts within that. Like Cynodon and Cypress cross reacts, and Sorghum and Ziames cross reacts. So I chose one among that. And I chose one among the weed pollen, considering the cross reactivity. And among tree pollens also, I chose depending on the cross reactivity. So this may be a little difficult for you to understand in if you don't have a good background of aerobiology and a cross reactivity. But the main reason that I put it up is even in polysensitized patient, you will be able to narrow down on allergens, limited allergens, depending on history and cross reactivity. And sometimes, even if a 4 5 allergens are present, we might still end up giving immunotherapy for only one allergen. And this monotherapy in polysensitized patient acts because of this therapy, what I would tell as a theory. Okay. Think, for example, the symptoms are contributed for aspergillus, dust mite, some irritant exacerbations, and a burst and one pollen peak. Now, I'm giving immunotherapy only for dust mite in this patient. So, though I'm treating only for the dust mite, and for the other things, I'm just focusing only on an environmental control measure. And this gray color zone is a patient symptom threshold. Patient is still not reaching that symptom threshold, even if I treat with only monotherapy. So, even by treating only monotherapy, you will still be able to achieve good amount of a symptom control in your patient. So, and it's always said that the monotherapy, the lesser you choose, better is the efficacy of your immunotherapy. So if there are 3 allergens which you narrow down as a culprit, one allergen, which is the most culprit allergen, which correlates with your history, more only you can choose for an immunotherapy. And other two, you might still focus on allergen avoidance measures. Okay. So how do we execute? There are different modalities that you execute immunotherapy. There is a subcutaneous immunotherapy, sublingual immunotherapy. So we start with a very high dilutions and then we slowly increase the strength of it. There is something called as an build-up phase and then there is a maintenance phase. Till build-up phase, patient takes injection almost twice weekly, and once the patient reaches a maintenance phase, then patient will be taking injection once in 4 to 6 weeks time. So these are the kind of a schedule, and patient takes it for a minimum duration of 3 years. 3 to 5 years is the duration of immunotherapy. And if somebody is practicing skit, that is subcutaneous immunotherapy, you have to be very well trained in your allergy management. You have to be thoroughly be trained for that, and disease should be very well be under control before you initiate immunotherapy. Before administration of every subcutaneous immunotherapy, you will have to do peak flow meter, and that has to be more than 70% of a patient personal best. And patient should be under observation post injection in your chamber for at least 30 minutes to watch for any adverse reactions that could happen immediately. And you should be giving in a center where you will be able to and also well equipped to handle anaphylaxis if at all, if it occurs. Okay. Some informations about slit is definitely appears to be very promising, very safer, happens at the convenience of a patient's home, works best as a monotherapy. But the other disadvantages are the no dose response curve is seen. So that means that it works as in thrice the dosage. It also works as in 120 times the dosage. So there is no dose response curve in slit. But there are few studies which have shown that higher slit dosage is better than the conventional dosage of what we give it as in 20 micrograms of a dust mite or a 50 micrograms of a pollen. So if you are giving by subcutaneous immunotherapy 20 micrograms per month, you could actually go higher in sublingual immunotherapy. But the biggest problem with the sublingual immunotherapy that we have right now is that it's not yet approved by drug general control of India, and I think you would have had some discussion on that. So that is the one thing that you should be aware while practicing sublingual immunotherapy. Some more tips while you practice immunotherapy is, see, immunotherapy is not that, it is an art. Immunotherapy is the science behind immunotherapy. You know that it is 110 plus years of an immunotherapy. But choosing these allergens, making your patient compliant, preparing this allergen immunotherapy recipe comes with a practice. It is an art. So for initial few years, work with your mentors for a few prescriptions. Okay. Choose monotherapy in the beginning, and it is a personalized medicine, and not everybody will respond in the same way, and not everybody will tolerate in the same way. There are patients where, where you easily go up to 1:50. There are some patients where you will be stuck at 1:250 for a longer time. You will have to take it slow. You have to probably order an interim dilutions also. Okay. Escalate and escalate pharmacotherapy according to patient symptoms. Very, very important. For a first 4 to 6 months time, do not even taper any pharmacotherapy, because that till that time immunotherapy is required, because only, as Dr. Sowmya had put up in her first one or two slide, the tissue level of eosinophil, everything starts coming down at what time? At around 6 months time. So till that time, pharmacotherapy, the solid pharmacotherapy has to be there. And you also need to tell your patient that immunotherapy is not a replacement for pharmacotherapy. You will still use pharmacotherapy during exacerbation, during season time. You might still need to take help of that for 1 or 2 months. You should know what to promise to your patients. Don't give some unrealistic promises to your patient. Plan your follow-ups and video consultations too. See, as you practice immunotherapy, you might start getting patients from, distance and all over. And patients may not be able to make a very frequent visits for end of each while. So at some point, you might also need to incorporate video consultation to understand the patient symptom scores and how to, up and down the medications, which some things which can be done on a telemedicine. So why these things are important is that helps you to keep your patient compliant. Now, if you tell that, no, you have to physically come and the patient has to come from 200, 300 kilometers away for you, patient might end up taking some more time to come, and then it is like, a time bound escalating treatment, and you have lost around 1 month in that. And then again, you have to go back to previous dose, or you have to go back to previous vials. So these are the certain things that you could do in your practice. So I've just put on these things. I think any more in the discussion that we could pick up before they take their exam MCQs or so. I'll stop my presentation here. Yeah, Dr. Shambho, any question answers? What are the HDM control? Yeah, so I think I have got a couple of questions on HDM control measures. I see that in the see, where does the house dust mite allergy come from? Okay, so these house dust mites are a very tiny creatures which are there in our bed sheet, bedspread, carpet, cushions, etc. So whenever we are sitting, lying down, part of our skin debris will be falling, and on that these dust mites will feed. They feed on our skin debris and they leave out their fecal matter. And these fecal matter are the one which actually contains the allergenic particle. Normally, our body is supposed to tolerate that, but your person who is sensitized will not tolerate that. Now, these dust mite proteins, there are 2-3 major proteins and there are many minor proteins. Most of these are a heat labile. Okay, so your avoidance measures also will focus on making this denatured, this protein denatured. So the first thing is frequent changing of the bed sheets, bedspreads, and these things. Wash them in a hot water. Yeah, before that, let me tell where all these dust mites will be there. So these dust mites will be there in our bed sheet, bedspread, and they will be there in carpets. They will be there in cushions. They will be there wherever the furry furnitures are there. But of all these things, the highest concentration of dust mites will be in bedroom. So frequent changing of the bed sheets, wash them in hot water plus sun drying. Okay, hot water is very, very important. Even if they change twice and if they don't use hot water, then it's not going to be effective. So hot water washing above 55 degrees and 3 hours of a good sun drying. So if a patient is not able to go do a sun drying, at least they can get it ironed. Bed you are not able to wash, bed you are not able to put it for a sun drying. So for bed, you put a special cover called as in mite encasings. So these mite encasings are a very tightly woven non-porous materials which will not allow the dust mite from bed to come up. Over that anyway you are using a bed sheets and you are taking care, right? So these mite encasings you are putting into the bed and you are zipping it. Wet mopping has to be practiced and no dry dusting. So you are not doing a dry dusting, but you are, wherever possible, you are doing a wet mopping. Regular HEPA filters may not be helpful, but regular vacuum cleaners may not be helpful, but HEPA filters, the vacuum cleaners with HEPA filters will be very useful. What you are not supposed to be doing is no soft toys, no furry furnitures. Air purifiers are not found to be of any benefit for house dust mite allergy, because these dust mite allergens are not like floating all the time. They are little heavy particles, so they become airborne and they get settled. So only which is airborne all the time only can be purified by air purifiers. So they are not of much benefit here. How long is the effect of immunotherapy? Is that there is a one question that I'm seeing here. The studies which were done on a skit is showing there are a couple of studies which I have seen the post skit effect, and I found that it was effective for up to 10 years time. With respect to slit, we don't have a good studies which are available which tells about the post immunotherapy effects. If you ask my practical experience, I don't have a patient who have finished immunotherapy and who have passed more than 10 years. But I have couple of patients from my senior colleague where there is a recurrence after 15 years. I have seen that, but I usually see that it is not as that bad as that they used to have symptoms earlier, which I can usually be managing with pharmacotherapy for 1 or 2 months. So 10 years is what you can, 8 to 10 years is what you can promise with the subcutaneous immunotherapy.
Yeah, madam, just want to add a few of our experience in our center because in Kolkata, the Allergy Asthma Treatment Center, we are providing allergen immunotherapy since 1988.
Okay.
So we had a very good pool of patients, and they are telling, we almost see 30 years, 35 years, and they are fine. And sometimes they take their next generation for this type of allergen immunotherapy. So we had that experience of 30, 35 years also. But again, this is a highly individualized. Many of our old patient who are coming back after 10 years, 15 years for again re-evaluation, and but of course they are telling their symptoms which were previously was much bad. Now
Correct.
it's not that bad.
Whatever the recurrence that I have seen is the same thing. Like, it isn't as bad as their previous listing. So where, there is very less cases where I had to reinitiate immunotherapy. They are, they're where you can usually manage with the pharmacotherapy. Dr. Krishnan is asking about the cockroach desensitization. As with our conventional teaching that you all have seen so far, that we don't do cockroach immunotherapy for a couple of reasons. That cockroach allergen has a very high protease and there is a auto digestion of these. And the cockroach allergen is a one thing where the avoidance measures are found to be beneficial. So it is quite often focused on allergen avoidance measures. See, at least cockroaches are visible insects, whereas dust mites are not visible insects. With all the avoidance measures that I have told you, if your bed had 1 million, you would have made it 500,000 by avoidance measures. So that alone wouldn't be enough. But whereas with the cockroach allergens, the avoidance measures are found to be successful. And we haven't practiced cockroach allergen immunotherapy at all. And that's what the conventional teaching also has been. I see a question by Dr. Bhaskar Krishnamurthy here. In case of cross reactivity on SIT, can we choose any of the antigens or any criteria to select one of them for allergen immunotherapy? Good question. See, what the doctor is asking is, now if I have a patient who is polysensitized to Amaranthus spinosum, let me take it as an Parthenium. And then there is one more pollen called as Xanthium stomarium, and there's one more pollen called as mugwort. Okay. So all these three pollens cross react. Okay, so now I'm choosing one allergen for immunotherapy. So how do I know that which allergen that I need to choose for immunotherapy? So I will choose pollen for immunotherapy depending on which is more prevalent in my area. So in my area, xanthin and parthenium is more prevalent than mugwort. So I will be choosing parthenium for immunotherapy among all three. But somebody practicing in north, you do have mugwort. You do have a good amount of mugwort, especially in Himalayan and sub-Himalayan belt. So they do have parthenium, but more of a mugwort. So they might choose mugwort over parthenium for immunotherapy. So this is one criteria. And then the second thing is the dimension of the wheel and flare. So anything more than 6 millimeter is actually clinically correlating. So depending on the dimensions of your the SPT reaction, and also if patient, this is one crude other method which I follow, is that, for if the three similar allergen the patient is sensitized and patient tells that the one is very itchy, I would choose that allergen for immunotherapy, because that is something which will similarly happen inside his nose too. Right. So we are translating what is happening in his nose on hand. So it is not written in any book. Okay. Don't write it in exams or tell it anywhere. But it is something that as in clinically that I judge that which is more itchy, I will also consider them for immunotherapy.
So I think another last question we can take, that if the patient is better or less symptomatic on pharmacotherapy, should we still go for immunotherapy? Asked by Dr. Batra from Delhi.
Yeah, so as I told you that it is not that all patients of your allergic rhinitis or asthma you jump onto immunotherapy. You see for certain criterias. If a patient is showing a progression of a disease, if a patient is having a strong atopic disorders, even with a mild disease and a good pharmacotherapy treatment, you would still start counseling on that, because the moment you stop pharmacotherapy the patient will have a recurrence of the symptoms, isn't it? Patient is doing good because patient is under pharmacotherapy. So that's what I usually tell. So you will be good as long as I'm putting you on medications, and what the patient wants, patient is in a hurry to stop me, making me stop steroids at any point. So if I stop that, disease will come back. So if you want that also to happen, that I will definitely want to start on immunotherapy. But it is not that, I jump onto immunotherapy immediately, but I'll give patients some time. I will, ask them, I will wait them to understand this, why immunotherapy along with pharmacotherapy may be required in these patients.
Thank you.
So somebody who is not, one thing that you need to understand is somebody who is not compliant to pharmacotherapy will never be compliant to immunotherapy. The biggest challenge that we have in immunotherapy is a compliance, right? So finishing a 5 days course of an antibiotic is difficult, and expecting to complete a 3 years course of an immunotherapy is not that very easy. The highest challenge that we have is not on, I would tell that it is not on a standardized, non-standardized allergens, or it is not on subcutaneous sublingual, it is on compliance is a big issue in immunotherapy. So if you make a way to understand how to make your patients more compliant, how to keep the follow-up schedule, so how to intervene in between, so if you understand good, then you are good at immunotherapy actually.
True. So thank you, madam. Thank you once again. So I think there is no more question, and we can close today this meeting. We have another examination session today. So once again, on behalf of Indian College of Physicians, I want to thank you, madam, and also Dr. Sowmya Nagarajan, madam, for this wonderful lecture series. And I think all of our participants, they are having they are really been benefited by this case discussion session. Many practical aspects were discussed today. So thank you, madam. And I am requesting all the participants. So we will start today's examination, and I think the link will be shared soon, and it will be activated from 11 a.m. So in between 11 to 12, you can submit your responses. After that, you cannot submit your response. But only issue is that when you are submitting your response, please write down the name of your in proper way. The spelling should be correct because that will be printed on the certificates. Along with, I am also requesting you to please mention your email IDs, email addresses properly in that Google form, because that one of our experiences is like that. Your email IDs are not properly given, so the further communications become difficult. So please put down the email addresses properly, and we are hoping that there will be 50 MCQs, and each MCQ will carry 2 marks. There is no negative marking. 60% is the cutoff mark. You have to get at least 60% for the certificate. So thank you once again, you all, for this accompanying us in this learning journey. And madam, thank you very much. If you have any final comments for our participants, please.
It's a wonderful program that you have taken up, Dr. Shambho. And I would just tell them that this is something that has ignited their knowledge, and if anybody finds it interesting, they should pursue more. This is something as an initial step, and they could take a further little more detailed courses for the similar these things, for the to make it as a more of an allergy practice. All the best for your exams too. Okay.
Thank you, madam. Thank you. So again, I want to thank our Professor Jyotirmoy Pal, who is the Dean of Indian College of Physicians, who was there from the very first day and help us, guide us to conduct this course successfully. So now it is the time for examination. So we will start the examination at 11 a.m. Thank you, Dr. Gayatri Pandit, madam. Thank you, Dr. Sowmya Nagarajan, madam. And wish you all a very good luck, our delegates, good luck for the examination. Thank you.